Picture this. It's 2 a.m. You're a med student on your first night float, or maybe a brand new PGY1. The hospital's totally quiet, right? And then, bam, your pager shatters the silence. It's the ER. You have a new chest pain admission in bed 4. Honestly, your own heart rate probably spikes right there. Are you ready for it? Well, welcome to this explainer. Today, we're taking that moment of pure panic and turning it into reflex-level confidence. We're going to master acute coronary syndrome, or ACS, so when that pager buzzes, you know exactly what to do.
All right, let's jump straight in. There's really no better place to start than the golden rule of cardiology. Time is myocardium. You've got to internalize this one. In the context of ACS, the clock is quite literally your biggest enemy. Every single minute that ticks by where we delay diagnosis or treatment, that directly equals dead heart muscle. It bumps up mortality. So on the wards, acting with reflex-level speed isn't just about looking sharp for your attending. It is the difference between life and death for the patient sitting in front of you. So here's the game plan for this explainer to build your mental scaffolding. First, decoding the ACS spectrum. Second, we'll walk through the critical golden hour. Third, EKG and troponin clues. Fourth, reperfusion and acute meds. And finally, anticipating deadly complications. Let's get into section 1, decoding the ACS spectrum. So a patient says their chest hurts. We need to know exactly what we're dealing with, because ACS isn't just one single disease. It's a spectrum of ischemia. And we basically drop it into 3 distinct buckets. First up, the big one, STEMI. You're looking for ST elevation in 2 or more contiguous leads, plus elevated troponins. What's actually happening here? It's a complete coronary occlusion, total blockage. It's causing a transmural or full-thickness infarct. Next bucket is NSTEMI. Here you might see ST depression or T-wave inversions, but troponins are still elevated. The occlusion here is only partial, leading to a subendocardial infarct. And finally, unstable angina. The EKG might be totally normal, and this is key. Troponins are normal. There's ischemia happening, but no actual cell death yet. Now notice how much we're talking about troponin. Just remember, troponin alone is never diagnostic. You absolutely need the clinical context, like the actual chest pain or EKG changes, because an elevated troponin can pop up in a dozen other totally different conditions.
And speaking of clinical context, it's wild how often real life completely ignores the Hollywood heart attack script. We all picture the classic crushing elephant on the chest pressure radiating to the jaw. But as an intern, you cannot anchor on that. Look at these atypical presentations: shortness of breath with 0 chest pain, epigastric pain that just feels like bad takeout, unexplained fatigue, passing out, or even a completely silent MI with no symptoms at all. You've got to keep your radar up, especially when evaluating women, the elderly, diabetics, and folks with chronic kidney disease. These atypical presentations are incredibly prevalent in those groups.
Moving on to section 2, the critical golden hour.
All right, the patient's here, they're clutching their chest, and the clock is officially ticking. This is where your reflexes are tested. This timeline, burn it into your brain. Within the first 10 minutes of arrival, you need an EKG, get them on a monitor, give them oxygen if they're hypoxic, and have them chew 325 milligrams of aspirin. Boom. By 15 minutes, you're pulling labs, CBC, BMP, troponin, and getting a portable chest x-ray to make sure it's not something wild like an aortic dissection. If that EKG shows a STEMI, by minute 20, you are calling the STEMI alert and getting cardiology on the phone. By 30 minutes, you're loading a P2Y12 inhibitor like clopidogrel and starting a heparin bolus. And at the 60-minute mark, assuming there are no contraindications, you're dropping a beta blocker and a high-intensity statin. It's a frantic, protocol-driven race. Treat this as your absolute, non-negotiable survival checklist.
Section 3, EKG and troponin clues.
Okay, you've ordered the tests and the data is rolling in. Let's do a quick hypothetical. Your patient has chest pain, but you look at the EKG printout and it is totally pristine. Normal sinus rhythm, no elevations, no depressions. Here's the question. Does a normal initial EKG completely rule out acute coronary syndrome? The answer is a massive, definitive no. Do not fall for this. It is one of the most dangerous myths you'll run into on the wards. Literally 10 to 20% of MIs have a completely normal or non-diagnostic initial EKG. If your patient is still having symptoms, you cannot just send them home. You repeat that EKG every 15 to 20 minutes, and you wait for those serial troponins. Say it with me. A clean EKG does not equal a safe patient.
Now, when the EKG is abnormal, this brilliantly illustrates what we're actually looking for. On the left, the STEMI. We want ST elevations of at least 1 millimeter in 2 or more anatomically contiguous leads. And the really cool thing about a STEMI EKG is that it's basically a treasure map. It's highly localizing. If you see those elevations in V1 through V4, you know the anterior wall is in trouble, pointing right to a blocked LED artery. On the right, for an NSTEMI or unstable angina, you're seeing ST depressions or symmetric T-wave inversions. That tells us there's subendocardial ischemia, a partial block, but it doesn't map out the specific coronary artery quite as precisely as a STEMI does.
Let's talk about the other half of our diagnostic duo here, troponins. Usually, we're using a high-sensitivity assay with a 0 and 3-hour rule-out protocol. What we really want to see is a serial rise or fall to call it an MI. Because like I hinted at earlier, a single high troponin without the right clinical story is a massive red herring. Just look at this differential list. Sepsis can elevate it through stress cardiomyopathy. A PE gives you right ventricular strain. Acute heart failure literally stretches the cardiomyocytes. Heck, even chronic kidney disease causes chronic elevation just because the kidneys aren't clearing it out. The main takeaway here? Always treat the patient, not just the blood test.
Part 4. Reperfusion and acute meds.
So we've got our diagnosis. Now we gotta fix the plumbing. If it's a STEMI, the absolute goal is to restore blood flow immediately. On the left here is primary PCI, percutaneous coronary intervention. This is the gold standard, period. Cardiologist goes in, balloons the block, and drops a stent. It gives you lower mortality, lower reinfarction, and a lower stroke risk. Our strict goal is a door-to-balloon time of under 90 minutes. Now on the right is thrombolytic therapy, giving IV clot busters like alteplase. We only use this if a cath lab is nowhere to be found within 120 minutes and their symptoms started less than 12 hours ago. The goal there is door to needle in under 30 minutes. But yeah, PCI is absolutely the preferred route if you can get it.
But fixing the plumbing is only half the battle. Every ACS patient needs solid medical management too. Just memorize the ABCDE checklist. A is for aspirin, hit him with a 325 milligram loading dose. B is for beta blocker, usually metoprolol, to chill the heart out and decrease oxygen demand, as long as their pressure and heart rate can handle it. C is your P2Y12 inhibitor, like clopidogrel, prasugrel, or ticagrelor. D reminds us they need dual antiplatelet therapy plus anticoagulation, so think a heparin drip. And E is for early invasive strategy, which means timing the cath lab based on how risky their case is. Now, there's a lot of nuance in risk stratification here, like calculating the TIMI score and figuring out exact medication dosing, so please refer to my IM notes for further details.
And finally, Section 5, anticipating deadly complications. Okay, your patients survived the golden hour, they're resting comfortably in bed, but honestly, your job is far from over. Let's map out this complication timeline, because the dangers change depending on how many days out we are from the attack. In the first few minutes to hours, we are terrified of cardiogenic shock and deadly arrhythmias like VT or VF. That's exactly why they're glued to continuous monitors. But look at step 2, days 1 to 7. The dead, infarcted tissue gets incredibly weak. You can actually see a papillary muscle rupture or a ventricular septal defect. How do you catch that? Literally by putting your stethoscope on their chest every single day and listening for a brand new holosystolic murmur. Moving to step 3, days 1 to 14, we're watching for free wall rupture, which leads to sudden tamponade and cardiovascular collapse. And then step 4, days to weeks out, you're on the lookout for autoimmune pericarditis, otherwise known as Dressler syndrome.
Consider this your ultimate ward's warning label right here. Early mechanical complications occur 1 to 7 days post-MI. Watch for sudden decompensation. The danger absolutely does not magically end the second they roll out of the cath lab. You have to stay hypervigilant, especially through that really fragile first week.
Well, look at that. We've decoded the spectrum, raced through the golden hour, cracked the EKGs and troponins, locked down the ABCDE meds, and mapped out those sneaky, deadly complications. You've got the scaffolding now, so I'll leave you with this final thought. Your pager is beeping. It's a chest pain admission in bed 4. Are you ready to go save some myocardium? Keep this explainer in your back pocket, trust your training, and stay curious. Catch you on the next one.